so I want to get to some practical issues, and we have a lot more to talk about. So let's focus in on some things that we need our audience to understand. One of them is, you know that the patient did or did not have an IDH2 mutation at the time of diagnosis. Do you retest at the time of relapse?
It's often the case that that mutation is present at relapse, but I would generally test because there are patients who will lose it, but that's uncommon.
Okay.
I wouldn't generally test. I would assume that if I
would
had
assume
that
it's there,
data,
but you know, if it wasn't there, I would probably look to see.
right.
But
And that's one of
I
the
don't think
reasons we do that testing.
You might start the prior authorization for the drug, but not be while you're waiting for the...
Again, it gets to the question.
Yeah.
It's a very expensive drug.
Right.
If the target isn't there, I guess you could treat and see what
But what
happens. If they
percentage of the time
respond
is it
by
lost?
the time the 3 weeks it takes to get the next gen back, you're going to know. But it can take months to find that out.
Yeah.
And while it's well tolerated, you know, you might choose an alternate therapy.
It is low. Okay, I know it was just because you were summarizing a lot of data. You forgot a very important toxicity that our audience needs to know how
Very
to manage,
important.
right?
Yeah, which is differentiation
There
syndrome.
you go.
Okay, so I can't talk about patients differentiating to a drug without saying, is that a good thing or a bad thing? It's a good thing because you're seeing response. It's a bad thing if they're getting sick from that response. And about 10 or 20% of patients on the study that led to the approval of Enasidenib, which mind you is a phase 1/2 study, it's not a phase 3 study. So across all these doses, that's how often they saw this. It led to leukocytosis. It led to patients developing fevers. It led to pulmonary infiltrates. In some patients, there was concern for cardiotoxicity in terms of pericardial effusions, pleural effusions, and it was steroid responsive. So in many ways, similar to what we see in APL when you treat with all-trans-retinoic acid, the ATRA differentiation syndrome and the Enasidenib, or really the IDH inhibitor differentiation syndrome, are largely overlapping, and the approach was the same. Once they recognized that this was happening in patients, they initiated quickly dexamethasone 10 BID until symptoms controlled and then taper off quickly. So patients don't wind up on months and months and months of steroids, but you should recognize that this is a risk in your patients, and you should be cautious initiating this drug in patients with pre-existing lung problems.
There's another practical element to that in addition to the management of these symptoms, which is the fact that initially these may sound like the patient is progressing.
Yes.
And we may have actually missed some responses initially when we didn't recognize these and we thought the patient, oh my God, is progressing, let's change to something else. So we need to recognize that also, again, not only to manage the symptoms, but also to know that that may be an expected effect, and it may be signaling response of the patient. Manage that. We use hydroxyurea to try to control that elevation of the white cell count. Let the patients continue, manage their side effects. And the other thing that is important, that's a little bit different on this drug, and probably in this other drugs will come in that have the same aspect, is that these responses will take a while. That this is not chemotherapy, that if you're not in remission in the first cycle, you're not going to respond. Some responses take months before you start seeing something, and even then they may continue to improve. May look only like a stable disease or a partial response, and they will get into a complete remission.
So that's a very important point. So in that study that was presented, the data was presented to the FDA, the median time to first response was 1.9 months, and the median time to best response was almost 4 months. At this Congress, there's important data being presented regarding the patients who at 90 days had stable disease, but who remained on therapy, and some of them achieved a complete remission. So practically speaking, Eunice, how do you decide, you know, you got a patient in front of you, persistently transfusion dependent or pancytopenic or in neutropenic infections. How long do you keep them on?
So I think this brings up a good point. I think it really depends on the patient. It's important to remember that this was not a phase 3 study. So this was a phase 1/2 study. And when you speak to the investigators that had this drug on study, the people they put on the study were elderly people, frail people maybe with advanced stage MDS that had an IDH2 mutation. These were not, 20, 30, 40-year-old young people that had an IDH2 mutation.
So people who don't have many other options either.
So the patient, if I had an older patient, refractory, relapse, failed some therapy, and they were cytopenic and they were on this drug, and say they're on for a month and a half, and everyone, my staff's like, they're not responding, they're transfusion dependent, I would persist. I would go out. I would say as long as There are hints of clinical improvement that are independent maybe of white count and things like transfusion independence, quality of life. Patients appreciate being able to take a pill and being outpatient. Decreased infections, maybe slowly over time the ANC has risen, maybe it's not 100%, 500, but it's risen to the point that they're not being hospitalized for infrequent infections. We're able to keep them on oral antibiotics. So I would persist. I think I would probably give it at least 3 months. I would say 2 months median is the median time to have a response, but I would say I would push it out to 3. And that if I thought that there weren't that many options for an older patient and they were potentially having some of those hints, I would continue. But I have to also point out that if I have a younger patient, refractory relapse disease, I put them on an IDH inhibitor, and I had a patient like this. He had a great response to the IDH2 inhibitor, had clearance of his marrow, he felt great, transfusion independence, and I said to him, you need to get a transplant. And he said, well, Dr. Wang, why do I need to get a transplant? I had this great response, and I had differentiation syndrome, and patients that get differentiation syndrome that have APL, they're all cured. So why do I still need a transplant? And why do I need a transplant in the first 6 months? I can't wait. And I think it's important to also point out that in that study that led to FDA approval, those 140 patients, that the median time of duration of the response was 10 months. Okay, so for healthier, younger patients, you have to be cautious that this is not a cure-all.
Right, and some
right?
are relapsing without the IDH2 mutation. Another clone grows out.
Right, so I think that this is a great agent, and I know there's ongoing studies adding it to chemotherapy, but for right now, you have to remember that if you have a younger patient, you get a CR, this isn't necessarily the same thing as APL that you'll be cured.
So the prescribing information says you should keep people on for at least 6 months, but I agree, it depends on what other options the patient may have. I may at 3 months or 4 months do a bone marrow to make sure things are going in the right direction, because if they're pancytopenic, maybe they're getting worse. So, and that's something we're gonna need to learn. Jorge, clinical investigation, okay, this is, I heard your boss the other day say, this is A plus B. You got 3 and 7, you got this drug, add them. Azacitidine, decitabine, add them together, okay? Any concerns about doing that? I mean, what's the rationale, I guess?
Yeah, no, I do have concerns because that's been our approach, because that's what we have available, and it sounds like okay, well, that's what we do.
Simple, right?
But it's, we little by little, we're definitely not yet. We need to evolve from that because this is, we may take away from the benefits of a drug like this, not only not get much benefit, but maybe even take away, that's potentially a possibility. It could be, for example, that although we think that 3+7 is, or whatever variation of that we do for the younger patients, maybe when you have a drug like this, maybe what you have to combine it is with azacitidine, for example, because the way they interact, it lends better. So I think we need to be careful with these combinations and be a little bit more biology-oriented, more preclinical. When you combine chemotherapy agents, sure, I mean, that's what you do. If this one works and that one works, that's fine, because they all work the same way.
We actually got rid of standard chemo from APL treatment, right?
Exactly.
Right. We actually got away from it.
But not with these biologically directed therapies. I think that we have to be very careful. I'm not convinced that just adding it to 3+7 on an IDH mutated patient will give us any benefit.